We are live now.
A very good evening to all our esteemed faculty members and all the delegates who have joined us for the AMOGS Medical Disorder Committee program with the Karat, Kolhapur and Ichalkaranji Society. At the outset, I would first like to wish all of you a very happy Republic Day in advance. And I welcome you all to this webinar, which is going to focus on the WHO Labor Guide. Let us all unite together for inauguration and an e-lamp lighting. Thank you, Saiti. At the onset, I would like to thank AMOGS President Dr. Pardeshi Sir and Secretary Dr. Sujata Madam for giving us an opportunity to conduct this webinar under the AMOGS banner. We are also immensely grateful to Jaideep Sir, Bharti Madam and Somsekhar Sir to accept our invitation as the chief guest and the guest of honors. And our faculties for today, Madhuri Ma'am and Bhaskar Sir, of course. Thank you so much for accepting our invitation. I would now take privilege to introduce Dr. Sneha Bhuyar Madam, who is behind the backbone for this webinar. It is her brainchild. Ma'am has won the International MS Signature Award for the Phenomenal Leadership for the Asia Awards. She is also the S.N. Malhotra Individual National Awardee for Outstanding Rural Obstetric Work. She is currently the chairperson of the Medical Disorder Committee, AMOGS, and has been the past chairperson of the Foxy Breast Disorders. We welcome you, ma'am, and I would like you to introduce our chief guest and guest of honor for today, ma'am.
Yes, thank you so much. A very good evening to all of you. I would just say a few words about this program. Once again, a very good evening to all of you. Respected Foxy President Dr. Jaideep Tang, who is the chief guest for today's program. Dr. Rajendra Singh Pardesi, my mentor, the president of AMOGS. Madam Sujata Darbi, Secretary of AMOGS, Madam Nandita Palshidkar, immediate past President, Dr. Kiran Kortakoti, the President-elect, and the entire team of office bearers of AMOGS. Guest of honor for today's program, Dr. Bharti, my dear friend, Bharti Abbankar, and Dr. Somsekhar Patil. The learned faculties for today's program, Dr. Bhaskar Pal and Dr. Madhuri Patel, the Secretary General of Foxy. The President and Secretaries of Kolhapur, Dr. Prasad Halkarnikar and Dr. Indranil Jadhav. Of course, the one-woman army, what I said, Dr. Preeti Deshpande, the team of Ichalkaranji, Dr. Shantinath Kole and Dr. Abhijit Sutar, all the chairperson, panelists, and of course, my dear friends, Monica and Madan. I welcome all of you for this virtual program. Birthing is an intense physical as well as emotional process, and as what I like what Jaideep said at Northern of Foxy, that we shouldn't say delivery, but we should say birthing, and it shouldn't be a normal delivery, but it should be a vaginal birth or a cesarean birth. And of course, this program is designed to enlighten what is WHO Care Guide and how it will help us to optimize cesarean section rates. I'll be moderating the panel in tackling the emergencies, and of course, Madam Madhuri Patel will be speaking on the difficulties in cesarean section. I welcome all of you, and I take this privilege to introduce Dr. Rajendra Singh Pardesi, President of AMOGS, a very humble, simple, genuine person, very inclusive. All of you know him as past vice president of Foxy, and of course the past chairperson of Food and Drugs Medical Surgical Equipment Committee. And sir, over to you for your precious words to guide all of us.
Good evening, everybody. Respected chief guest, Dr. Jaideep Tang sir, guest of honors, Dr. Bharti Abbankar, Dr. Somsekhar Patil, Dr. Kiran Kurtakoti, Dr. Sujata Darbi, and our mother figure, Dr. Madhuri Patel, and our guest, Dr. Bhaskar Pal, and our AMOG chairpersons, Dr. Sneha Boyar, Dr. Monica Obardhan, and Dr. Madan Kamble. First, I wish to congratulate Dr. Sneha Boyar, Karad, Kolhapur and Ichalkaranji Society for organizing such an academic and practical webinar on labor and LACS, and it will really help in reducing maternal mortality. We wish to bring it down as single digit. As Maharashtra, now maternal mortality is 33, and we wish to bring down it single digit. And these programs, these trainings and guidance by dynamic leaders like Dr. Bhaskar Pal and Dr. Madhuri Patel, I think we will achieve this. I wish every success to Dr. Bhaskar Pal and Dr. Sneha Boyar for their future endeavor in FOXI as President and Vice President elections. Wishing every success to this webinar. Thank you. Thank you so much for inviting me. Thank you.
Thank you, sir. Thank you so much, in fact, for being so supportive and so inclusive. Now I take this. I think Dr. Jaideep has still not joined. So I would just take this opportunity to invite and introduce our guest of honor. Saiti, can we have Dr. Bharti Abhankar, who is the senior obstetrician from Kolhapur and of course the senior vice president of AMOGS, a very accomplished person and a very dear friend. Dr. Bharati, can we have few words of wisdom from you? Over to you, Bharati.
And sorry for delay in joining. It's my laptop.
Welcome, Madam Madhuri Patel here. And yes, over to you, Dr. Bharati.
Yeah, very good evening. And thank you, Sneha, for giving me this opportunity for being a guest of honor. We all know how hardworking Dr. Sneha is and how a good academician plus a worker, I can say, for FOXI, for AMOGS, everywhere she's always there. And I have attended her webinars and they're really a very good academic feast for all of us. So I wish you all the best. And today's speakers, I should not talk about them. They are a very best academician. And I just want to say a few lines about Dr. Madhuri Patel, because her work as a secretary in FOXI is really wonderful. In a fraction of minute, she responds to whatever your queries are. She has helped me a lot in whatever programs I conduct of colposcopy training. Recently, she has helped me a lot. So I once again thank you and wish you great success in your tenure.
Thank you so much. Thank you, Bharti, and thanks especially for gracing the occasion. Now I take this privilege to introduce our dear friend, Dr. Somsekhar Patil, who is a senior obstetrician from Mirrors. He was initially in the medical college and we traveled the same journey. Of course, he's a private practitioner, very accomplished person as well, and he's a postgraduate teacher for CPS teachers for last 20 years. Dr. Somsekhar, we would like to listen to your experience as well as your precious words from you.
Hello, good evening, all of you. First of all, I thank you all for inviting me and making me the guest of honor. And as far as all the faculty that is concerned are all eminent. I've heard them many times. And today also it will be a great feast. And Dr. Sneha Boyar, I know her, met her many times. I've enjoyed your delegations and plus as a co-person in many of the national and international conferences. So today will be a great feast and I wish you all the best and I request all others to consider and support all your candidature. And again also Dr. Bhaskar Pal, a very good academician. I have also enjoyed his academic deliberations. Though I am not in the association office bearer, I was earlier, but now I'm more concentrating on the private practice and my CPS. So I am ready to whatever the responsibilities that you all think you can give. So thank you very much and I wish you all the best for Dr. Sneha, Dr. Bhaskar Pal, and my regards to all other participants of this seminar.
Thank you so much, Dr. Somsekhar, for your precious words and your best wishes as well. With this, we declare that the inauguration is done for this academic session. Once again, I think Dr. Jaideep has some emergency. Initially, he was just about to join, but he has to rush for some emergency. So if at all he joins later, we can have his precious words. And with this, I thank all the dignitaries. I hand over the academic session to Dr. Madan and Dr. Monica. Thank you so much, all of you, once again.
Thank you, ma'am. Thank you all the esteemed dignitaries for joining us for the inauguration session. At the outset, I would like to first thank the Karad, the Ichalkaranji and Kolhapur societies for helping us with this webinar and collaborating us with on this. The first session for today is the WHO Labor Guide. The speaker is none other than Bhaskar Pal sir, and our chairpersons for today's session, Dr. Preeti Deshpande madam. She's the president of the Karad OBGY Society. He is a director at the Ekopa Hospital and the Karad Fertility Research Center, practicing infertility consultants in the last 20 years. She has many awards to her credit, including the Indumati Zaveri Award as well as the Tulsi Basu Award for the best research paper. We welcome you, ma'am. Our next chairperson for today's session is Prasad Haranikar sir. He is the president of the Kolhapur OBGY Society, is in the private practice since quite a lot of time, and his main areas of interest includes infertility and vaginal surgeries. Ma'am, I hand over the session to Preeti ma'am to introduce Bhaskar Pal sir.
Thank you for the nice words. Am I audible?
Yes.
Yes, ma'am.
Yeah. Thank you. At the outset, I'd like to thank Sneha Madam, chairperson of the AMOGS Medical Disorder Committee, and the candidate for vice president. Best of luck, ma'am. And thank you so much for making Karad Society a part of this academic session. And my regards to all the senior gynecologists, Pardesi sir, Bhaskar Pal sir, Madhuri Patel madam. And and it is my honor to introduce Dr. Bhaskar Pal sir. He, as Pardesi sir just described, a great academician. Dr. Bhaskar Pal sir doesn't need any introduction. He has served the various gynecological societies at various positions. He has chaired the endoscopy committee, SAFOG. He has chaired the AICC RCOG 2021-23. He's been the immediate past president of IH. He's the FOXY representative. He was from SAFOG to 2021 to 2023. He's chaired the organizing committee of AICOG 2023 Calcutta.
Dr. Preeti, that should be okay.
Yeah, actually, because this can just go on and on. So I request sir to start the session on WHO guidelines for labor care.
Thank you for the kind introduction. And I thank Dr. Sneha and Dr. Pardesi for inviting me. And I bring you virtual greetings from Kolkata. Those of you who've been in Kolkata are possibly familiar with the iconic Victoria Memorial and the Howrah Bridge. This is the Howrah Bridge lit up in teal for breast cancer awareness. It is done for 1 month every year. I'll be speaking on WHO Intrapartum Care Guideline. The WHO Intrapartum Care Guideline has a background. Now, the majority of the 140 million births that take place around the world are without any risk factors. Having said that, the intrapartum period is critical to maternal and neonatal survival because something just might crop up and go wrong. And morbidity and mortality would increase if any complication arises. The SDG 3 target is to ensure a healthy life and promote well-being for all at all ages. And the global strategy for women's, children's, and adolescent health from 2016 to 2030 does talk about having a positive childbirth experience and having a respectful maternity care. Now, this expands the focus to ensure that women and their babies, and not only that they survive labor complications in case they occur, but also that they thrive and reach their full potential for health and life. So it is not only a question of reducing mortality, but also a question of reducing morbidity. Now, the big problem is that we talk of normal labor. The concept of normality in labor and childbirth is neither universal nor standardized. It has been handed over from textbook to textbook, different editions without anybody questioning. And in the past 2 decades, there has been a substantial increase in application of a range of labor practices, either to initiate labor or to accelerate labor or to regulate or monitor the physiological processes of labor. At one point of time, we were talking of active management of labor with the aim of improving the outcome for women and babies. But this increasing medicalization tends to undermine the woman's own capability to give birth and negatively impacts her childbirth experience. And also the increasing use of labor interventions in the absence of clear indications widens the health equity gap between high and low resource settings. So what is positive childbirth experience? It is identifying the most common practices that are used throughout labor to establish norms of good practice for conducting uncomplicated labor and childbirth. What it does is elevates the concept of experience of care as a critical aspect of ensuring high quality labor and childbirth care and improved women-centered outcomes. Given the fact that most childbirths would be uncomplicated, the woman's experience of care is a very, very important point. Childbirth is a physiological process that can be accomplished without complications for the majority of women and their babies. So the positive childbirth experience is a significant endpoint for all women undergoing labor. It is defined as one that fulfills or exceeds a woman's prior personal and socio-cultural beliefs and expectations, including giving birth to a healthy baby in a clinically and psychologically safe environment with continuity of practical and emotional support from a birth companion or birth companions and kind, technically competent clinical staff. This is based on the premise that most women would want a physiological labor and birth, and they would want to have a sense of personal achievement and control through involvement in decision making, even when something goes wrong and medical interventions are needed or wanted. Now, this guideline is actually valid for healthy pregnant women who have no identified risk factors for themselves or their babies, and they otherwise appear healthy. So the WHO agenda was to provide high quality care for all pregnant women and their newborns throughout the pregnancy, the childbirth, and the postnatal period. So what WHO did was it published 56 evidence-based recommendations in 2018 to achieve desired physical, emotional, and psychological outcome by providing effective practices that support and, more importantly, avoiding ineffective and potentially harmful practices that hinder a woman's own capabilities during the birthing process. The guiding principles for the intrapartum care guideline is that labor and childbirth should be individualized and it should be women-centered. No intervention should be implemented without a clear medical indication. Only interventions that serve an immediate purpose and have been proven to be beneficial should be promoted. And a clear objective that a positive childbirth experience for the woman, the newborn, and her family should be at the forefront of labor and childbirth care at all times. So the recommendation has got different categories. First is recommended, where the intervention or option should be implemented. The second group is not recommended, which is intervention or option which should not be implemented. The third group is recommended only in specific context, only to the condition, setting, or population specified in the recommendation, and should only be implemented in this context. For example, if we say all vaginal births should be looked after by midwives, that is not something which is possible in India. So it is recommended only in context where there is a midwifery-led care. And the fourth group is recommended only in the context of rigorous research where we are still looking for answers. This is the WHO intrapartum care model. And as we said, respectful labor and childbirth care is at the forefront of it. It requires emotional support from a companion of choice, effective communication by staff, pain relief strategies, regular labor monitoring, documentation of events, audit and feedback, oral fluid and food intake during labor, mobility in labor and a birth position of choice, a pre-established referral plan if something goes wrong, and lastly, continuity of care. So respectful maternity care throughout the labor and childbirth maintains women's dignity, privacy, and confidentiality. It ensures freedom from harm and mistreatment. It enables informed choice and continuous support during labor and childbirth. And the care throughout the labor and childbirth insists on effective communication between healthcare providers and the woman, that the woman is allowed to have a companion or more than one companion during labor and childbirth. I don't know about Maharashtra. In West Bengal, now the government has made it mandatory to allow one companion during labor, and continuity of care. Midwifery-led continuity of care models in settings with well-functioned midwifery programs. So this is a context-specific recommendation. Now, clinically, the most important changes come in our definitions of labor and definitions in terms of progress of labor. So latent first stage is now defined as painful uterine contractions and variable changes of the cervix, including some degree of effacement and slower progression of dilatation up to 5 centimeters for first and subsequent labors. So latent stage is still 5 centimeters and not 4. Active first stage is regular painful uterine contractions, a substantial degree of cervical effacement, and more rapid cervical dilatation from 5 centimeters unto full dilatation for whether it is first labor or whether it is subsequent labors. So latent stage is up to 5 centimeters, active first stage is 5 to 10 centimeters. Now about putting durations on the stages of labor. The latent first stage of labor has no established duration. It can be hours, it can be days. Active first stage, which is from 5 centimeter to full cervical dilatation, in first labor, we can allow up to 12 hours, and in subsequent labors, we can allow up to 10 hours. So, which means that it is even less than 2 centimeter per hour in a priming. So what is not recommended? What we've read in the books for years, cervical dilatation rate threshold of 1 centimeter per hour during the active first stage. We do not recommend the use of medical interventions to accelerate labor or birth, such as oxytocin augmentation or a cesarean section, before 5 centimeter cervical dilatation, provided the fetal and maternal conditions are reassured. Routine clinical pelvimetry on admission is not recommended, doesn't prove anything. The passage of the baby's head is the ultimate test. Routine CTG on labor admission in healthy pregnant women in spontaneous labor is not recommended. What is recommended is auscultation using a stethoscope or a handheld Doppler or a Pinard stethoscope. Routine perineal or pubic shaving prior to giving birth is not recommended. Administration of enema is not recommended. Continuous CTG in low-risk women is not recommended. Routine vaginal cleansing with chlorhexidine is not recommended. Active management of labor for prevention of delay is not recommended. Doing amniotomy just for prevention of delay is not recommended. Early amniotomy with early oxytocin augmentation for prevention of delay is not recommended. By all means, do that if it is clinically indicated, if you're worried about the fetal condition. Oxytocin for prevention of delay in labor in women receiving epidural analgesia, not recommended. Antispasmodic agents for prevention of delay is not recommended. And intravenous fluids for shortening the duration of labor is not recommended. None of these are useful or evidence-based. What is recommended that we should delay the labor ward admission until the active first stage, which means that we should not be shifting women to labor ward before 5 centimeters. We should assess by a vaginal examination in the active first stage every 4 hours. We should listen to the fetal heart by intermittent auscultation, which is every 15 minutes in the first stage and every 5 minutes in the second stage, with auscultation of 1 minute after a contraction. And if after a contraction has passed off and we can still hear a bradycardia, that is called a post-contraction bradycardia, and that is equivalent to having late decelerations or type 2 decelerations on CTG. What is recommended to is allow women oral fluid and fluid intake during labor and encourage the adoption of mobility and an upright position. For healthy pregnant women who request pain relief in the first stage of labor, epidural analgesia is recommended, so are parenteral opioids, relaxation techniques, and manual techniques like massage or application of warm packs. What about the duration of second stage? In first pregnancy, first labor, we can allow up to 3 hours. In subsequent labors, we should allow up to 2 hours. Adoption of a birth position of choice, including upright positions, is allowed for women and recommended whether they have an epidural analgesia or not. Now, techniques to reduce perineal trauma and facilitating spontaneous birth, including a perineal massage, a warm compress, and a hands-on guarding of the perineum, is recommended that this decreases the chances of a perineal tear. Women in the expulsive phase should be encouraged and supported to follow their own urge to push. Women who have an epidural analgesia, we can delay the pushing for 1 to 2 hours after full dilatation or until the woman regains the sensory urge to bear down, provided there are resources available for longer stay in the second stage, and we can really assess for perinatal hypoxia. What is not recommended in second stage of labor is routine or liberal use of episiotomy or a manual fundal pressure to facilitate childbirth. In the third stage of labor, it is recommended to use uterotonics for prevention of PPH as active management of third stage. We should also delay the umbilical cord clamping for at least 1 minute and up to 3 minutes, and we should use control cord traction when skilled birth attendants are available. What is not recommended is sustained uterine massage to prevent PPH in women who have received prophylactic oxytocin. What is recommended that we should assess the uterine tone abdominally for early identification of uterine atony, more important in the first 1 hour after delivery. Regular assessment of vaginal bleeding, uterine contraction, fundal height, temperature, and heart rate routinely during the first 24 hours, starting from the first hour after birth. The blood pressure should be measured shortly after birth, and if it is normal, it should again be taken within 6 hours. The urine void should be documented within 6 hours of birth. What is not recommended is routine antibiotic prophylaxis for women with uncomplicated vaginal birth, whether they had an episiotomy or not. As far as the newborn is concerned, newborns without complications should be kept in skin-to-skin contact with the mother during the first hour after birth to prevent hypothermia and also to promote breastfeeding. All newborns, including low birth weight babies who can breastfeed, should be put to the breast as soon as possible after birth if they are clinically stable and the mother and baby are ready. Newborns should receive 1 milligram of vitamin K intramuscularly after birth, and bathing should be delayed until 24 hours after birth. The mother and baby should stay in the same room 24 hours a day, which is the rooming in. Now, this guideline, when delivered as a package, will ensure good quality evidence-based care irrespective of the setting. This guideline is neither country nor region specific and acknowledges the variations that exist globally, and it highlights the importance of women-centered, individualized, and effective clinical and non-clinical practices to optimize the birth outcome. So what is important that we take a patient approach in labor. We do not medicalize this unnecessarily, and we make the woman a part of any decision making if something is going wrong. Thank you very much. As told by Dr. Pardesi, I seek your blessings and support for the elections which will happen in the month of August for the post of Foxy President. Thank you very much. I'm happy to take any questions.
Prasad sir,
Yes.
yes, for your remarks, sir, and
Yes. Thank you, Bhuyar Madam, for giving this opportunity to Kolhapur Obstetric and Gynec Society to participate in the webinar. It is always a pleasure to attend academic sessions arranged by Madam. Thank you, Pal sir, for enlightening us on this daily topics our interaction, and mainly the aspect of maternal part in this session, because till date we were not so much concerned about this aspect. And thank you, Pal sir, for this wonderful lecture.
Yeah, I think the past president of AMOGS, Dr. Nandita Palshetkar, when she was the president of Foxy, she brought in the concept in Foxy of the respectful maternity care. And I think that is entwined in the theme of our Manyata project.
we can see Jaideep sir, he is joined. I welcome you, sir, and we thank you for sparing your precious time for us. I would like Sneha ma'am to welcome sir.
Yes, Saiti, if you can display Sir CV.
Yes, ma'am. Sir has not connected the audio, I think. We will wait for 1 minute more.
Ma'am, in the meantime, you please introduce
Yes.
sir. I will call him up, ma'am.
Okay. So, Dr. Jaideep Tank, he is the president of FOXI at present. He was the Secretary General of FOXI, with whom we have worked. Under his able guidance, we have served as chairperson for FOXI. He's the project lead for FOXI USAID project from 2020 to 2024, and also the Deputy Secretary of Asia Oceania, that is AOFOG. He is the past chair of Publication and Newsletter Committee, AOFOG. He's awarded FRCOG honoris in 2020 by the Royal College of London. And also he's, all of you know him as a senior consultant obstetrician, a very genuine, inclusive person, very encouraging and inspiring personality, I would say. It was our pleasure to work under him as Secretary of FOXI, and I'm very happy that whatever program we invite him, he's always there to support and guide. Has Dr. Jaideep joined?
Yes, ma'am.
Yeah. So good evening, Dr. Jaideep, and welcome. So it's a new introduction. I was talking about President FOXI, and we welcome you for as AMOGS first program, you as a chief guest. So over to you. We are eagerly waiting to listen to you.
Thank you, Sneha, for inviting me here. It's always a pleasure and a privilege to be a part of any program which Sneha conducts. I worked with her very closely when she was the chair of the best committee of FOXI, and the work that she did was really exemplary. She set the bar very high, and congratulations, Sneha, for all the wonderful work that you've done, and all the best for all your future endeavors in FOXI. Let me also acknowledge Pardesi sir, Nandita, Dr. Dalvi, and Kiran, all the office bearers of the AMOGS, and of course the presidents and secretaries of Karat, Kolhapur, and Ichalkaranji societies who have come together to organize this webinar. It's also a pleasure to be chief guest when the guests of honor are Dr. Bharti Abhyankar and Dr. Patil. Sneha, you put together a very important and very comprehensive program with the WHO Labor Guide being elucidated upon by my very dear and good friend Bhaskar. All the best, Bhaskar, for all your future endeavors, with Chairpersons Preeti and Dr. Prasad. And of course, the next very important topic of difficulties in cesarean by our own Secretary General, Dr. Madhuri Patel. I've heard Dr. Patel speak on this topic, and I think it's one of the best talks that you will hear. So congratulations on selecting both the speaker and the topic. And of course, the chairpersons, Dr. Kole and Dr. Jadhav. And finally, of course, there's this very important discussion on labor drills moderated by you with Dr. Manisha, Dr. Mohini, Dr. Aparna, Dr. Sutar, Dr. Gauri, and Dr. Arushi as panelists. Thank you also to the coordinators, Monica and Dr. Madan. And it's always a pleasure and a privilege to be a part of any program which you organize, and of course, which is an AMOGS activity. Thank you very much for having me here, and wish you all the very best for everything. Thank you.
Thank you so much, Jaideep. Lots to learn from you, being so methodical, so strategic, and so inclusive. I'm very happy to have you as chief guest for today's program. And of course, thank you so much for all your support and wishes. Thank you so much once again.
Thank you. Bye.
Thank you so much, sir, for joining in as a chief guest and giving your words of appreciation for each one of us. Thank you, Bhaskar sir, for an elaborated talk on the WHO Labor Guide, and our chairpersons, Preeti Madam and Prasad sir, for chairing the session. I would now like to invite Dr. Madan sir to carry the next academic session forward.
Thank you, Dr. Monica. Yeah, we will move on to session number 2, today's activity. I invite chairpersons Dr. Sheetalnath Kole sir and Dr. Indranil Jadhav.
Thank you, sir.
Hello.
Yeah, thank you.
You're
Thank you,
audible, Madan, you can continue.
Yeah, I would like to introduce Dr. Sheetalnath Kole sir, who is the chairperson for this session. He's the presently he is the president of Ichalkaranji OBGY Society, and he is practicing as senior consultant at Ichalkaranji. Next, Dr. Indranil Jadhav sir. Yes, he is currently secretary of Kolhapur OBGY Society, consultant IVF and gynecologist. I welcome both, and I request Dr. Kole sir to introduce the speaker, Dr. Madhuri Patel madam. Over to Kole sir.
Thank you, Madan sir. Good evening, everyone. Thank you. First of all, I would like to thank Sneha madam for chairman of the Medical Disorders Committee for arranging this webinar. And now we have next speaker, Dr. Mrs. Madhuri Patel, and she will be speaking on difficulties in cesarean section. This is the topic which is very near and dear to everyone's heart, because we in day-to-day practice we have to conduct cesarean sections, and we face a lot of problems. Sometimes knowingly, unknowingly, we'll end up in a situation where we need to tide over the crisis. And to elaborate on this topic, I would like to invite Dr. Madhuri Patel madam. Madam is a Secretary General. Right now, she is a Secretary General of FOXI. She was Joint Secretary of FOXI in 2009. Is a committee member, FIGO, Preterm Birth, Associate Editor of Journal of Obstetrics and Gynecology Society of India, Honorary Clinical Associate of Nauroji Wadia Hospital, Parel, Bombay, Honorary Consultant, Police Hospital, Mumbai. He is a visiting consultant at St. Elizabeth Hospital, Mumbai, and former professor and HOD OBGY at MGMH, Mumbai, and former associate professor, GMC, Mumbai, India. She has been awarded the AMOGS Mrs. Shailaja and Narayan Pandit Award for the year 1920. She has delivered guest lectures at national and international forums, keynote addresses, and oration, and she has, to her credit, more than 50 publications in national and international journals. So over to Madhuri Patel madam, and she will be speaking on difficulties in cesarean section. Welcome, Madhuri.
Thank you, Dr. Sheetalnath, for your kind and warm words.
Yeah,
Respected Chairperson, Dr. Sheetalnath and Dr. Indrani, and our President, Dr. Rajendra Singh Pardesi, who is my great friend since last 2 decades, and of course, Dr. Nandita, another great friend, Sujata, Kiran, Kurtakoti, we all are very, very dear friend to each other. And of course, with that, Jaideep, with whom I have worked for last, 15 years, and our Dr. Bharti Abhyankar, the guest of honor. She is a, very nice person, and she told me that I got the work done. So I am really happy that, at least, Bharti, we had done so much of work, and at least I'm in the FOXI to get the work done for everybody. So anytime you require any assistance from my side, you are most welcome, and I will definitely solve your problem. Secondly, I would like to mention that, today's topic, can I share my, screen?
Yes, you can share, ma'am.
So this topic is very close to my heart, that is difficulties during cesarean section. All of us are aware that whether you have done 1,000 C-section or 10,000 C-section, but next section is going to be same or different, that only after section we come to know. So we all have to be prepared for the worst thing and take out the best for the mother and the baby. So cesarean birth is an unnatural method of a natural event. However, cesarean section can effectively prevent maternal and perinatal mortality when done in a medically indicated patient. There is a sustained, unprecedented rise in cesarean section rates worldwide, which is a major public health concern. In 1985, it said that it should not be more than 15%. But recently, it also says every effort should be made to provide cesarean section to a woman in need rather than starving to achieve a specific rate. If you see all worldwide, this is 2018 Lancet publication says that in Dominican Republic it was 58.1% and in United States it was 32.9%. So our Union Ministry of Health and Family Welfare under the Health Management System, the report of 2019 says the overall C-section rate was 23.4%. And this was, if you compare the rural area and the urban area, the rural area, that is the population, say in 2000 it was 6.3%, and after a decade, that is in 18 and 19, it doubled to 13.9%. And in private facilities, it was 17.1% in 2008-9, and after a decade, it became 33.8%. That is, it doubled. So we should not say that cesarean rates are increasing, but we should say we are optimizing, and Dr. Ajay Mane said we are rationalizing cesarean section rate, because the other hand, we see the perinatal and the maternal morbidity and mortality have reduced drastically. So we are rationalizing our cesarean section rate. This is not moving. Okay. So it is commonly perceived that the cesarean section is a simple and safe alternative to the difficult vaginal birth. But remember one thing, if the cesarean section in vaginal delivery is going to be difficult, cesarean section is also going to be difficult one. So what are the difficulties which can arise during C-section? Difficulty in abdominal access, difficulties with uterine incision and closure, abnormal placentation, difficulty in baby delivery, difficulty in placental delivery, difficulty in controlling hemorrhage, and difficulty during abdominal closure. So I will take one by one point on this. So all of us are aware that now abdominal incision, when we have seen during residency as paramedian, left paramedian, vertical, now it has gone. Now we have all switched over to the incision. However, vertical midline incision should be kept for the emergency section. So when you take a financial incision, if you don't have proper access, sometimes you may have to do a muscle cutting incision, and therefore when you cut the muscle, you have to be very careful to ligate or cauterize this bleeder, especially ligate. Otherwise, in the night you will have to come to open the abdomen for the hematoma drainage. Now we are also facing difficulties with the previous cesarean section, because what happens in my practice, I have seen there is abdominal layers are all adherent. They are adherent. It takes time to deliver the baby. One thing, they don't bleed much. Then you have to be careful when you open the parietal peritoneum. You take your peritoneum incision as high as possible to avoid the injury to the bladder, bowel, and omentum. Then when you open the uterovagal fold of peritoneum, you may find difficulty in during previous cesarean section because it is adherent. So that time you can proceed with the sharp dissection instead of blunt dissection. Normally we bladder we mobilize with the sponge holding forceps, and that time your sponge holding forceps should be only in the midline to mobilize the bladder. If you take at the side, the patient is going to bleed from the bladder plexus, and it is going to give you lots of stress. And once the bladder plexus bleeds, you do not keep on taking the stitch. You just keep a mop, warm mop or any mop, give a pressure, and it will stop bleeding. Then when you take an incision on the uterus, it should be in a curvilinear method. So the chances of involving uterine artery, if it gets extended, are less, and you should have enough space to deliver the baby. You may have to take inverted T-shape incision, and sometimes you may have to take a classical, you may have to do a classical cesarean section because of the multiple previous surgeries, densely adherent bladder, fibroid in lower segment, cancer cervix, and nowadays we lost many patients with placenta accreta syndrome. So now myomas in the lower segment, when we are doing, in the past we never used to touch the myoma because we were so worried. As a resident, I was taught, don't touch the myoma, otherwise patient is going to bleed to death. But now it has been proved with the several research papers that if it is coming in your way of incision, you should remove this myoma. Whether you remove myoma before the delivery of the baby or after the delivery of that baby, it will depend upon the obstetrician skill. And once you remove the myoma, you should close the dead space by the delayed, absorbable suture, that is white. We can see the dead space are properly closed and it are not bleeding, and you can cover this, myoma, incision with the retrovertebral fold of perineum. You remember, these patients are likely to have postpartum hemorrhage, and it has been reported when the myoma is more than 5 centimeter, and elderly patients, especially more than 40, they are likely to have more postpartum hemorrhage. So these are the patients should be treated in the center where all the facilities are available. So now look at the abnormal placentation. The abnormal placentation is your placenta previa, and I mentioned as today we are seeing, placenta increta, accreta, and percreta. Nowadays, sonography facilities are available everywhere, including in rural area. So it is very easy to identify whether we are dealing with placenta previa or placenta accreta, increta, percreta. Sometimes you may not be in a position to diagnose whether you are dealing with increta or percreta. You may diagnose on the paper. Such patient also requires, delivery cesarean section at the higher center where all facilities are available. Now let us look at this video that it says that, sorry, can you hear the voice? So here we are doing, hello, can you hear me? Can you hear me?
Yes, ma'am. Yeah.
Yes, madam.
Am I audible?
Yeah.
So there is something, and can you hear the background, of the video?
Noise is coming.
Can you hear the background of the video? Anyhow, I would like to say that when the placenta is not a major degree, you can insulate your finger below the placenta and deliver this baby. Here we are doing that. You can see over here, and once it is delivered, you can do as it is. But if the placenta is, covering completely the lower segment, then you have to cut through this placenta and deliver the baby. But when you are cutting through this placenta, remember one thing, that baby can bleed because it is bleeding from the baby side. So baby can bleed from that side. So now let us look at difficulty of baby delivery. It can be with the floating head, deeply engaged head, abnormal position and presentation, transverse lie or breech presentation, reflex head, prematurity, multiple pregnancies, fetal malformation, and congenital twins. And I'm going to say about a few of these cases. So you see many commonly, floating head at term. In prime especially, multi you may have a floating head, you have to give vaginal delivery because she has previously delivered. But when you see floating head in a primary gameter ectom, you have to be careful about cephalopelvic disproportion, deflex head, and cord around the neck. And you should also, see at laparotomy when we are taking for a cesarean section. This is a floating head, and we are at the uterus now. We follow peritoneum. So what majority of the people do, they open the take the incision the uterus, open the uterine cavity, and liquor should be drained very slowly with assistant giving fundal pressure, and this flow drainage of the liquor will help to get the head in the incision, and then you can deliver this baby. I remember that at this stage also, when we are doing with the floating head, the baby can turn and you may have to deliver by breech presentation. So the other possibility is the application of the forceps, where if you are well versed with the forceps, you should use this forceps. But remember, in vaginal delivery, forceps applications are left and right blade, while here they are anterior and posterior blades, which you can see over here. So the sagittal suture of the baby should be in a transverse position. You apply the posterior blade, apply the anterior blade, and if the blade has a pelvic curve, small pelvic curve, then it should face towards occiput, and you should deliver with the forceps. But I would also like to mention, forceps delivery on cesarean sections are not easy. You have to be well versed with that, otherwise you will give more problem to the mother and the baby. Another thing, our obstetrician use ventouse. That is also a very good option for the floating head. It takes little time, but the delivery of the baby occurs very, very comfortably. So let us come to the now deeply engaged head. When the patient has a deeply engaged head, then you have to understand that she has majority of time they are into deep transverse arrest. That means there is cephalopelvic disproportion and patient has gone into obstructed labor due to deep transverse arrest, and the cervix is fully dilated. So this patient requires a C-section. She requires a proper head low, proper relaxation of the abdomen, the relaxation of the incision site, that is good anesthesia, and catheterization is done for all the patients. Similarly, you should do over here. You may get hematuria because of the obstructed labor. Now, if the incision is low down at the head, you try to put your hand below the head, but the head is impacted. It is not possible. So you ask your assistant to push the head from below, which is also going to be difficult. So you have to remember, this is an impacted head. It is going to be difficult. In foreign countries, what they have, pillow, fetal pillow. What they insert fetal pillow, at the time of catheterization, the plate is inserted, and at the time of uterine incision, they inflate the pillow, which increases the elevate it by 3 to 4 centimeter, so making the easier fetal head delivery. But nowadays we don't have, but Ondom is going to be launched. Let's see how we can go ahead. So this is where the incision is low level. But if your incision, because the lower segment is well formed, thinned out, and now your incision is right at the shoulder. So what you're going to do, when it is at the shoulder, there is now the back is, anterior. When the back is posterior. As usual, we deliver one shoulder, then we deliver both the feet, then we deliver the trunk, and then we deliver the other shoulder and the head. So when this is posterior, but when the head is anterior, it is very, very difficult to deliver this, baby, because the liquor has drained away. She is in the obstructed labor. The baby is embraced by the uterus, and now we have opened this, where the shoulder comes over there, trying to put the fingers below the presenting part, that is head, it is not possible. So it is decided we will do the Patwardhan technique of delivering this baby. So the one shoulder is out, the other shoulder is out, okay, and just see how difficult to deliver the trunk. We have to pull. Just see, the delivery of the trunk is very difficult, okay, but you have to deliver without getting scared or worried. The trunk is delivered now. You can see how difficult, and I think you must experience such situation. The legs are out and the head is out. So these are the when the deeply engaged head is there. So in transverse lie, another challenging cases, if you are diagnosed at in an antenatal period, she is registered, it is better to do a C-section at 38 weeks where she is not in labor and liquor is adequate and you can deliver as breech. But if it is an impacted shoulder presentation where the liquor is drained away, then it is very difficult to do this section because the baby uterus is impacted on the baby, and you may have to take inverted T-shaped incision. And when you do this section, you have to be worried about postpartum hemorrhage and sepsis. So you have to keep blood ready and you have to start with a higher antibiotic. I would like to narrate one case, of this, transverse lie that she, when I was resident at 32 to 34 weeks, she was registered patient. She came with impacted shoulder presentation because the liquor had drained away and we had to do a C-section for a dead baby. And there also we had to take inverted T-shaped incision. Second time also the episode was, repeated. And third time we kept her admitted and we did a planned section at 32 weeks. And she went home with the baby with the third section. So these are the difficulties we can find, but we have to find out the solution. Now, breech delivery we hardly see nowadays, except the patient comes with the breech at perineum. But remember, when you are doing the C-section for the breech delivery, all steps of vaginal breech delivery remains the same. The difficulty usually arises for the aftercoming head. So what in my practice I do, I catch hold the baby's leg and I tell the assistant to push the fundus and take a long up, what you call as Burns and Marshall technique, which has in the axial position and the delivery of the head becomes very easy. Otherwise, you can do Mauritius Malibet technique. Multiple pregnancy, nowadays we find elderly patients with the assisted reproductive techniques, they are conceiving, and that's why we are taking all the patients for C-section. But you can deliver this patient vaginally when the first is vortex. If the first is transverse of breech, then we know that we have to go for a cesarean section. But remember one thing, when you're delivering vaginally, when you are delivering per abdomen, you deliver the first baby and second baby. If it is transverse lie, then you have to do the internopodalic version, and otherwise vertical lie, then for the second baby, you may deliver as a breech or vertex, whatever the presentation is there. But they are likely to have postpartum hemorrhage, so you have to be prepared with that. So our aim is the atraumatic delivery is the goal of an obstetrician, and possible causes of injury to the because sometimes we are in a hurry and we can give an incision on the part of the presenting part of the fetus, and then it is a problem. Then secondly, if the incision is inappropriate, not inadequate, and if you do hasty delivery because of the fetal distress or for some other reason, then baby is going to get trapped in the incision and going to give problem, and you have to solve. You will have to extend your incision laterally or vertically. Major injuries, we know it can be head, neck, shoulders, spinal cord, abdomen, or limbs of the baby. So we have to see that we take a proper incision. Don't be hasty to deliver this baby. Take your own time and do the delivery very well. And as an obstetrician, you are supposed to know all the maneuvers, because it is an emergency. You have to deliver and you should know all the maneuvers, when you are dealing with this C-section. Now, difficult placental delivery, nowadays we have adopted during section also. The controlled cord traction is preferred over manual removal. In the past, we used to do manual removal, so you get a feeling that how to do a manual removal when during one delivery. But nowadays, we control cord traction even during cesarean section to reduce the blood loss. Now, the challenge is adherent placenta. If the placenta is completely adherent, she is not bleeding, you can leave the placenta as it is, but you have to monitor this patient. You have to keep them for a long time for, look for sepsis and secondary PPH. Post-op methotrexate nowadays nobody is using and it is not recommended. Difficulty on placenta delivery, I say that adherent completely, you keep it there and follow up, keep the patient admitted for a long time and look for sepsis and secondary PPH. But when it is a partially adherent, then the patient is going to bleed. These are the patients, are going to be a difficult one, and you may end up with all the resuscitative measure, bilateral uterine artery ligation, bilateral internal artery ligation, and cesarean hysterectomy. So this PASS syndrome usually end up with cesarean section. But we have another, I have mentioned to say that another PASS syndrome, there is a method called compression suture with, uterine artery ligation with istomocervical suture. So what we do after delivering of the baby, you ligate the uterine artery bilaterally, and from the stomach to cervix with a straight needle, you go anterior to posterior and again come back to posterior and take 2 stitches. And then before tying the stitch, you put a cervical dilator so you don't obliterate the cervical canal. So this is another method, and then you remove the placenta. This is another method of conservative surgical management for the placenta accreta syndrome instead of going straight to the cesarean hysterectomy. Now, closure of the uterus. Especially, when you are doing closure of the uterus, when cervix is fully dilated, you have to be careful because your incision may be in the vagina and you may not notice it. And so I will definitely like to narrate another my experience that when I was unit head and my lecturer was doing on the other table cesarean section at fully dilated cervix, and I was doing the abdominal hysterectomy. She came and told me, "Madam, I have completed the section. Everything went fine. But at the time of vaginal toilet, patient started pouring. We had to explore her immediately, but we could not see vaginally. So immediately on the same table, patient was not shifted. So we opened her up, and what we found that she has nicely sutured anterior, lower and the upper edge of the uterus, which she thought, but it was basically, it was a 2 lips of cervix. She thought that this is the incision of the uterus, which was nicely, stitched. And from the lower edge of the vagina, she was bleeding, and on the upper edge of the vagina was retracted. So we opened the cervical stitch and then took off from the lower vaginal edge and the upper part of the retracted vagina. We took a stitch and we completed the suturing, and patient went home nicely. So here again, I recommend that you should deliver. I deliver uterus after, while taking the suture on the incision of the uterus. So it helps me in 2 ways, that I don't suture the posterior wall of the uterus. At the same time, I know I put a cervical artery forceps or my finger in the cervical canal to confirm that I am in the cervical canal. There are theoretical, embolisms are there, chances of embolism when you deliver the uterus, but I see many benefits. So it depends upon the obstetrician whether you want to deliver uterus out of the abdomen by taking the suturing the uterine incision or keep inside. So now I will conclude this, that as an obstetrician, it's our duty to mother and a healthy baby to the family and nation. If C-section is better mode of delivering the baby, we should opt for it. But as an obstetrician, you should know each and every method if you face the difficulties, and this will definitely reduce maternal and perinatal morbidity and mortality. Thank you once again, AMOGS and Sneha and Madan and all our expert public awareness, Monica and Dr. Sujata and Dr. Rajendra Singh Pardesi for giving me this opportunity. Thank you once again. So I would like to end that sometimes you may face difficulties not because you are doing something wrong, but because you are doing something right. So right time, when you do right thing, still you can face the problem. So once again, thank you, all of you.
Thank you, Madhuri Madam, for your wonderful deliberation. I request the chairpersons, Dr. Indranil sir, to give inputs, and also Dr. Kole sir.
Yeah, it was a nice informative session. Actually, there were some 3 key points which were discussed. The first key point was like we are afraid of rising cesarean section rate. But at the end of the day, healthy mother and healthy baby is our motive. So you should actually see for the perinatal and the maternal morbidity rather than thinking that if she delivers vaginally or by cesarean section. This is the first conclusion we can have. Second conclusion, we often see that like cesarean section is just another surgery, but we may face difficulties. So in my context, there should be 2 things that should be done. That you should always inform some other obstetrician that I may be in help while planning a cesarean section. And second thing, in our exams, in obstetric exams, we have manuals, different manuals for delivering baby vaginally. The same way we should also teach our PG students that for difficult cesarean section, how we can deliver a baby. And third and the foremost important thing is as we have discussed that if the baby has floating head or placenta is adherent, so there may be n number of complications which may not be seen on a ultrasound. So keep calm and cool. Let the cesarean section progress slowly with the least trauma, with the proper layer to layer dissection. We are not getting awarded a Nobel Prize for delivering a baby within 15 minutes. So take your own time and be the surgery may be flawless or maybe the least blood loss which we can expect. I just hand over to Kole sir for his further regards regarding the session.
Yeah, thank you, Indranil. And once again, thank you, Madhuri Patil Madam, for this wonderful lecture. It was very elaborate and she has touched upon almost all the aspects of difficult cesarean section. As I said earlier, it is a topic very near and dear to our heart because day in and day out, we have to do cesarean section. We may need to do cesarean section almost daily. Then, and at any time, we may come across a problem and we need to get rid of that or we need to tackle that. And she has wonderfully explained all the difficulties we face and how to tackle all these difficulties, and this will help all of us in our day-to-day practice. It will go a long way in our practice. Thank you, Patil Madam.
Thank you, Dr. Kole and Dr. Indrani. Thank you, and Dr. Sneha. Thank you.
Thank you, both the chairpersons, Dr. Kole sir and Dr. Indranil Jadhav, for chairing the session and your valuable comments. And thank you, of course, Dr. Madhuri Patil ma'am. You're fabulous at every time. Thank you. Thank you for coming with us today. I declare the session number 2 is over. Now we will move on to session number 3, that is panel discussion on labor drills. Dr. Sneha Bhuyar madam will moderate the panel.
My introduction has been done. Madan, thank you.
Yeah.
You can go ahead.
Yeah, I will introduce the panelists for this session. Dr. Manisha Laddad madam. She is past president, Karad OBGY Society. She is associate professor in OBGY at Krishna Institute, Karad. Second, Dr. Mohini Deshpande. She is consultant at Genesis Super Specialty Clinic, Kolhapur. She is also aesthetic gynecologist. Dr. Aparna Kololkar, she is assistant professor, CPR Hospital, Kolhapur. Dr. Abhijit Sutar, he is currently secretary of Ichalkaranji OBGY Society. Dr. Gauri Shinde, she is assistant professor of KIMS Karad. And Dr. Arushi Kazwe, she is consultant obstetric gynecologist at Ichalkaranji, city of Ichalkaranji. I welcome all the panelists, and I would like to hand over to Sneha Madam for further proceedings.
Thank you so much. Once again, Madan, thank you so much for conducting the session so flawlessly, Monica and Madan. And after listening to the very important talks, I'm sure you all are ready to face all the emergencies. And let me take this opportunity to share my screen and welcome all of you to this case-based discussion. Can you see my screen?
Yes.
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 Yes, ma'am.
So, as we have talked already, childbirth is a sentinel event in the woman's life and her family as well. Birth is intensely emotional as well as physical, and that is why maybe everybody are talking about the birthing process, may it be a medical personnel, a social, or a legal person. It's not that easy as 1, 2, 3, and 3 pushes and the baby is delivered and everything is happy. The aim of this labor is, of course, a healthy baby from a healthy mother, as we have been listening to all the time. And of course, it should be an emotionally fulfilling experience, not only for the mother, but for the obstetrician as well. We have been listening to the labor care guidelines, what WHO has come up recently. But I'm sure all the obstetricians sitting here, maybe from my generation and the one who are sitting, the new generation, they are still confused. What we were taught, different. What they were being taught, it is different. 4 decades ago, it was, masterly inactivity and watchful expectancy. And then around 3 decades ago, when I was a PG student, that time the concept of active management of labor, and all of us were O'Driscoll's followers. Right from early labor, we used to have some interest to that extent that we used to even have program labor. Once again, considering the very high rate of cesarean section and the rising morbidity and mortality, people are again becoming the proponent of the masterly inactive. Do the needful only when it is needed actually. So that is how the concepts keep changing, and we have to be updated. And to this now, all of us are here to discuss. And with this, we now discuss the first case. We have this grand multigravida in this era, little difficult, but yes, we do get sometimes 35-year-old patient who delivered by dye at home. The placenta was also removed at home, but suddenly the patient started bleeding profusely, and she was brought to the labor ward. Her vitals, pulse rate was 120, BP was only 90 by 50 millimeter of mercury. I'm sure you got the provisional diagnosis, but when I provide you this further information, per-abdominally uterus was not felt. She was bleeding profusely, and when you examine, large fleshy mass was seen at the vagina. Hello?
Hello?
Yes, can you all hear me? So, Dr. Manisha?
Am I audible?
Yes, you are audible. See, this is
Am I audible?
situation.
Yes.
What is your diagnosis, and how will you tackle this case?
As you have explained this case, so there are multiple risk factors in this case. First is a multiparous. Second, the delivery is conducted at home by the untrained person dye. And when patient, there is a possibility
You please
PH or maybe patient stand up in shock. So there is a possibility of second possibility is a uterine inversion. So these are the 2 nightmares where patient comes with profuse bleeding immediately after the delivery. and having a vitals affected, that is tachycardia and hypotension. So most probably this must be a case of either uterine inversion or atonic PPH.
So there is a large flaccid mass in the vagina. What is it?
Okay. So if there is a mass in vagina, so most probably this is definitely it is a case of uterine inversion.
Correct.
As all of you know that uterine inversion, day by day, the incidence of uterine inversion.
Please unmute yourself.
The incidence of uterine inversion is in 1,000. Hello, am I audible?
Yes, yes.
So the incidence is almost 1 in 1,000 to 1 in 2,000 deliveries. So there are multiple predisposing factors for uterine inversion, like elderly gravida, multiparous women, or precipitate labor, or whenever there is an induction of labor done and having a prolonged delivery. So all these cases are prone for having a uterine inversion.
How will you manage this case? We will not talk about the theoretical aspect. How will you manage this case?
Okay, so this is a dial emergency. So first of all, I have to call for help because immediately, along with immediate reposition of the inverted uterus, I may require help of anesthetist. I will require the help of my senior consultants, or as well as a teamwork is required. So immediately I will call for help. And on table, if possible, if I diagnose immediately as a uterine inversion case, I try to repose it by making a cup with my hand.
Dr. Manisha, I just interrupt you here. This patient has been brought to us from outside. Okay, they have, delivered, they have removed the placenta. When she started bleeding, then they have brought to us. Okay, so it is not immediate uterine inversion. So definitely you would need to manage this patient by giving anesthesia. But by the time, what can you do for resuscitation of this patient? She's already in shock.
Meanwhile, one side we have to stabilize the patient hemodynamically. We have to start large bore needle, that is IV fluids. Immediately we have to send the sample for cross matching, and we have to inform to the anesthesia team.
Okay, then.
And at the same time, if possible, I will try to repose the this inversion if possible. But anyway, if immediately the patient is shifted to the operation theatre, and I will request my anesthetist to give a good anesthesia, like general anesthesia, because I required a full relaxation. Because as this patient is delivered by the relatives, so sometimes there may be constriction has been formed, and I will get difficulty to repose this uterus. So I will require a good general anesthesia.
Okay.
So there are different methods of this reposition. One method is manual reposition, where we have to make a cup, 4 fingers in the posterior fornix and thumb in the anterior fornix. And the principle what we have follow in the inversion uterus is we have to repose that part which comes last. And in that way, we have to repose the uterus. Sometimes we can use a fist and try to push that inverted uterus gradually in the upward directions. That way, we can reduce the incidence of perforation of the uterus. So manual reposition will be the first line of treatment, and most of the time, 99% of the cases we have seen that patient gets corrected with that manual reposition.
What next?
If in spite of that, if the patient is this inversion is not able to repose, then there is a hydrostatic.
I'm saying that you have corrected it successfully. Now what will you do?
Yes, when I corrected, at the same time, I have to keep my fist in the uterine cavity. Second hand should be above the pubic symphysis, and I will try to maintain the uterine contour, and so that uterus gets well retracted. At the same time, we have to start oxytocics like pitocin 20 units in IV drips, or if required, we can give injection prostudine or methargine injection for this patient.
Correct. How long do you want to give these oxytocics? How long do you want to continue this infusion?
At least we have to give it for half hours. Next drip has to be continued.
It has to be at least 6 to 12 hours. Okay, because the uterus, first and foremost, you have to keep the hand for some time inside. You give uterotonics immediately, and you support the uterine contour from the opposite hand, and you watch for the uterine tone, correct? And then, of course, you have said that you have to maintain the tone. But you have to maintain the tone up to 6 to 8 hours at least. See that it doesn't recur. Okay.
Okay.
So suppose it fails. You were not able to do that. What else you can do?
There are O'Sullivan method that is also called as hydrostatic correction of uterine inversion.
Yes.
Nowadays, it is absolute. We also in institute, we have never used this method for reposition, but this theoretical aspect, if we consider, we have to push a saline into the genital tract in the vagina, and we close the that is outlet of the labia majora with the fingers or by using sponge holding forceps, and we try to push that uterine inversion by hydrostatic pressure method.
Correct.
But here we have to take a care that the drip which we have started, that should not be more than 3 meter height, because there is a chances of embolizations. The study has proved
Yes.
chances of embolization in that cases.
Yes. What else? Suppose this also doesn't work. Then what is the role of?
So yes, the conservative approach by then finally we have to go for emergency exploratory laparotomy, and where we try to pull that uterus from upward direction, where we can use Halton's method or Huntington's method. Meanwhile, we have to, as you say, that we have to do the catheterization, that already things we have done at the time of labor room only when patient gets admitted. So surgical methods, we use either Huntington's method or Halton's method. So in where we have to open the abdomen and identify the round ligament and hold that round ligament with the Alice forceps and try to pull the uterus in upward direction. That is the one way. Sometimes there is a constriction ring and where we have to cut, that is Halton's method, where we have to cut the posterior, that is lip of the cervix, and where we have to brought up the uterus upward direction by pulling it either with Alice forceps or by sponge holding forceps.
Okay. What is this method of simple milking the whatever uterus has been inverted, the fundus has been inverted, so you flip the fundus upward, and
yes,
then
yes.
with the help of Alice you can definitely pull
yes,
it.
Yes,
okay.
yes.
Correct. And what is the one anterior colpotomy and posterior colpotomy, if at all you
Yes,
need?
that is Halton's method we can use.
Yeah. And then there are a few others where you have to just complete the discussion because you are from the medical college, definitely. This is
Yes,
the
yes.
ring. You cut the cervical cervix, you dilate the ring, you pull the uterus up, and then
Yes.
you suture it. That is all.
Yes.
And this is also a few of the other methods.
There are certain studies they use venous cup also for reposition from the upward direction by taking laparotomy incision.
Correct. That is one. And of course, there are few more, the anterior and posterior, Kushner's and Spinelli's method. That is the colpotomy. You open it up and pull the uterus fundus.
Yes, yes, yes.
So post-operatively, definitely you need to keep the oxytocin
Yes, yes,
for
yes.
8 to 12 hours and see that it is not recurring. And of course, you have handled it so much that you have to give broad spectrum antibiotics. All these procedures has to be done with utmost aseptic and antiseptic precautions. Okay. So of course, you being in medical college, you all are very thorough about these methods. But I'm sure majority
Recently, madam, we have one case. We have actually.
Yes. Say that.
Recently, we have one case. And suddenly after delivery, along with the placenta, there was a uterine inversion. But luckily, the anesthetist was with us. So immediately he intubated the patient, and we have reposed that uterus immediately and then removed the placenta. But in that patient, the etiological factor for uterine inversion was a defective myometrium. That lady doesn't have myometrial layer in between the endometrium and serosa. It was very thin walled uterine wall was there, and that was the reason where we got a inversion in a primigravida without any other risk factors.
Okay, so that is a good share, in fact, and I'm sure all the other obstetrician sitting here definitely they find this is quite a novel case, and you really don't, as you have said, actually the incidence is becoming very rare, 1 in 20,000 that has been quoted recently, and of course. Faulty management or mismanagement of third stage of labor, as you have rightly pointed out, you're giving unnecessary traction on the cord. I think that is the one which the message here is you have to actually go by what is called as Brand Andrews method, that is controlled cord traction. So that is how the message we have to take care to prevent the uterine inversion. And of course, if at all it happens, you have to manage the way you have described. So thank you so much, Dr. Manisha. And now we come to Dr. Mohini. Mohini,
yes, ma'am.
Are you here? Good. I'm very happy.
Yes, ma'am. I'm
here. Yes, and definitely we'd like to hear from you. You have this primigravida, 37 weeks in early labor. you find that the vitals are good, contractions are only 25 seconds every 4 minutes, the head is floating, fetal heart is absolutely fine. And after some time, you find a sudden drop in fetal heart rate. So the contractions are not so strong, but there's sudden fetal heart drop. So what is your diagnosis and how would you manage this case?
So since the contractions are not very good intensity or good duration, she is only in latent phase of labor, must be, and her fetal heart has been absolutely fine. The sudden drop in FHI will first bring the suspicion of maybe a cord since the head is floating. So it could be a cord presentation or cord collapse. However, I would like to confirm by two things. First, I will like to auscultate after the contraction passes for at least 1 minute. To know whether it is a late or variable, and whether it is a prolonged deceleration. And the other thing is I would like to do a pervaginal examination to confirm. Since
Before that, would you like to go for a post speculum examination? What do you suspect here?
Since there is a sudden drop and if it is prolonged, then I would suspect cord prolapse more than a cord presentation.
Yes.
And so the cord could be present in the vagina.
Rupture of membranes you need to rule out. Yes.
Yes. So the cord could be present in the vagina, even if it is not prolapsed outside the vagina. So yes, I would like to go for a per speculum. If I see the cord, it is always better to not touch the cord frequently.
Yes.
However, if it has prolapsed out of the vagina, I would like to push it inside the vagina with my fingers and keep it so. And to keep it so, I would definitely want a team approach for this. One person will, I would like to instruct to
What
do
will be your
retrograde filling
aim?
of the bladder.
What is your treatment aimed at? What is your aim of the management?
So it will, ma'am, it will depend on whether the fetal heart rate is present or cord pulsations are felt or not.
Yeah.
And if the fetal heart rate is present, I
I'm
would
telling you,
definitely
there is
want
a sudden drop in fetal heart, and now you have to manage the patient.
So we have a live fetus here, and we want to give a healthy baby to the mother. And so I would definitely like to go for expedited delivery in the form of cesarean section, since she is only in latent labor.
Yes.
So I would definitely want to go for cesarean section. So on one hand, I would like someone to prepare her for cesarean section, take the consent for guided fetal prognosis as well as emergency cesarean section, and one person will do retrograde filling of the bladder to prevent the cord from prolapsing out more with about 300 to 500 ml of normal saline, and give the patient a left lateral position or a knee chest position with oxygen by mask. So I would like to do all of this together simultaneously till the patient is shifted to the operation theater. Also, I would like to inform the neonatologist at the same time, and obviously the anesthetist.
Yes. Suppose you find that you do her examination, her membranes are ruptured. You do a internal examination, you find that she's almost 8 to 9 centimeter dilated. Now what will you do?
In that case, if the effacement is also good, if she has started getting good contractions, then I would like to deliver the patient vaginally. If at all the cesarean section is going to take time, if the anesthetist is not immediately available, I would want to proceed with a vaginal delivery for this patient then. For that, I would definitely see to it that I'm not pushing the head while doing vaginal examination. I will see to it that I'm not pushing the presenting part up while doing vaginal examinations, and I will start with oxytocin and try to deliver the patient.
We want to push the presenting part up because that is causing compression of the cord, right?
Yes, ma'am.
Yeah, but then you are right in a way that you see, the moment you see that the fetus is in distress, you will prepare everything for cesarean section. But meanwhile, when you examine, you find maybe she will deliver faster vaginally than the cesarean section, and that is a situation where you would try to hasten or augment the delivery, maybe by using some instrumentation. I think that's the only answer we can have from here, correct? Because it is a distress, we have to deliver the baby earliest by whatever route she can deliver comfortably. Okay.
Yes,
so now, as you have talked about, cord prolapse, I told you that, when you do PV on PS, two things can happen. You see, do her per speculum examination, you find rupture of membranes leaking, and you see cord somewhere. That is a very frank case of, frank cord prolapse. But sometimes you find that there is no leaking and there is no cord also.
Membranes are intact.
Yes.
So when the membranes are intact, but the cord is below the presenting
But then it is
part.
not felt. When it is felt, it is phonic presentation or cord presentation. You could not feel it, but it is lying somewhere by the side of the head and it is getting compressed. Okay, so that is occult cord prolapse. Okay, so this is how you have to differentiate clinically. Now we come to Dr. Aparna.
Yes, ma'am.
Yes. So Aparna, what are the predisposing factors? Not for this case. We have managed the case well. But as an obstetrician, we should know the predisposing factors, and of course, we should be able to avoid the exacerbating factors. So what are the predisposing factors for cord prolapse?
Before we discuss about predisposing factor, we should know the overall incidence of cord prolapse. It is around 0.1 to 0.5% in the population, but in non-cephalic presentation, the incidence is high, that is around 1%. First, we should know the physiology behind the pathophysiology behind the cord prolapse. When the presenting part is very high, it is non-engaged, the cord will have space between lateral pelvic wall and presenting part. So cord can easily slip from that space and get below the presenting part. How that cord presentation will happen? If membranes are ruptured, it is cord prolapse, and if membranes are intact, it is phonic presentation, as you already said, madam. So the predisposing factor can be prematurity, preterm labor when membranes are intact, or premature rupture of membrane. It can be PPRM or PRM, where membrane can rupture. Otherwise, other conditions are multi-fetal pregnancy, where again malpresentations are common. Most common malpresentation is like transverse lie, followed by complete breach, frank breach, unstable lie, which is very common in multi-parous women, and polyhydramnios, where liquor is very high. Most of the time in polyhydramnios, presentation is maybe variable, it keep on changing. So chances of cord prolapse is very high in such condition. And there are certain iatrogenic conditions where cord prolapse are very common, like when we are doing ARM routinely, when head is not engaged and contractions are not adequate. That time, and other is like external cephalic version, but nowadays we are not doing external cephalic version that frequently. So I feel the risk of cord prolapse in such case is very theoretical. Then internal podalic version, when we have to deliver the second baby. That time, cord prolapse can be common. Second is again like when we are dilating the cervix, means inducing mechanical induction of labor by balloon Foley's catheterization. That time also chances of cord prolapse can happen.
Especially when the fetal head is not very well fixed, it's not well applied to the cervix. And you're trying to dilate it and manually rotate it. Sometimes, good old days, we have seen our seniors doing that. And you have a space in between the pelvic walls and the presenting part. And that was a time, where the cord used to just escape. So these are all the, antepartum risk factors, and these are the intrapartum risk factors. We will not go into the theoretical details. But what does RCOG talk about this? As you have said, the incidence is so low, but the clinician have to be very aware about this, because even if it is 0.1 to 1%, if that happens to you, you are in trouble, and it's going to be a case for discussion. Of course, in all the clinical meetings, maybe there will be a medical legal issue for you. So how would you, if the patient comes to you as antenatal case, how would you advise her?
Ma'am, when we are vigilant, what are the risk factor, what is the background for cord prolapse, we are more vigilant, and we know cord prolapse can happen in such cases. But even if the occurrence of cord prolapse are very highly unexpected, even in cephalic presentation. But in high-risk cases, like in our OPD, that is polyhydramnios, malpresentation, transverse lie, or unstable lie, or multifetal gestation where presenting part is so high, we should counsel the woman at 37 weeks of gestation in the OPD. So see, like you should get admitted at 37 weeks. If you don't want to get admitted at 37 weeks of gestation, when SROM occur, means spontaneous rupture of membranes occur at home, you should alert and immediately you should admit as early as possible, because chances of cord prolapse is very high. So you should counsel such patient in OPD.
Yes, but is it only the counseling sufficient, or you have to write it down as an informed written
Informed
consent?
consent should take.
If the patient is not willing to write it down, at least you explain her. You write in your own handwriting and you sign that saying that I have explained the patient and relatives and they are not ready to get admitted. So that, you know, at least you are aware of it and you have not committed any negligence here. That is taken on the paper. That is how. So suppose, you know, you have this, so what other precautions? You have said what does RCOG recommend about this?
Sir, NHS has guidelines for prevention of management of cord prolapse. Let us think cord pneumonic as they have mentioned. So C for consider the cord prolapse. O for organize the help.
Yeah.
And R for relieve the pressure. Relieve the pressure by any method like position, niches position, or exaggerated Sims position, or retrograde bladder filling, or you can keep the 2 fingers in the vagina and elevate the fetal head to relieve the compression. And D for decision for the birth. I mean, how you are planning this delivery. Either you are trying vaginally or you are doing crash section. So this is the another mnemonic. For this mnemonics is help in the rural area, PSC, RH, where the facilities are not there for doing cesarean section. So these midwives or sisters or even interns, they can call the ambulance. Ambulance should be fully equipped with the senior obstetrician, and neonatologist should be there. If contractions are good, then we can give tocolysis also at the same time, and we can shift that patient in such condition in the ambulance, and immediate we can do delivery or cesarean section in tertiary center.
Yes. So Aparna, you are talking about the mnemonics which are there for management of cord prolapse. Here we are talking about the guidelines for the prevention of cord prolapse. So here what they have advised is, if the woman is around 37 weeks and if she has transverse slide breach, any of the malpresentations, and she's got polyhydramnios, you have to advise her admission and write that she needs admission. You have to warn her and take it in writing. That is one. Secondly, whenever you diagnose cord presentation or a floating head, you must avoid, rupture of membrane. You must warn them about spontaneous rupture of membranes. Whenever you diagnose the cord presentation, you have to, opt for cesarean section without giving any choice for induction of labor or rupture of membrane whatsoever. So early identification of the patient at risk and early detection of cord presentation of prolapse and the prompt treatment, that is what the RCOG says, to minimize the complications for cord prolapse. So very well discussed, Dr. Aparna.
Thank you.
And now we move to the third case. I hope all of you are finding it interesting. So do we have Dr. Gauri?
Yes, madam.
Yes. So we have this 28-year-old gravida 4 with 3 previous abortions. Now this lady has 39 weeks of pregnancy. She's in labor. She delivers a full-term baby and the placenta is not expired even after 45 minutes of birth. So how would you manage this patient?
So first of all, thank you, madam, for giving me this chance. So she is 28-year-old, 4th gravida. She had a previous 3 abortion. She delivered, but 45 minutes placenta not delivered. So I want to give here a differential diagnosis. It can be a simple retained placenta or it can be a adherent placenta. So if it is a simple retained placenta,
Dr. Gauri, we will first talk about the clinical management and then we will talk about the theoretical aspect for prevention.
So after doing the pars speculum examination, if we consider that it is a simply retained placenta and not delivered, we can just start with the ecbolics and the placenta will get delivered eventually. But after doing that also, if the placenta has not delivered, that means we are dealing with a adherent placenta. So it can be a simple adherent placenta which we can deliver by taking the patient under anesthesia and simply by delivering by manual removal of placenta. But
okay, so my query here, should we go for ultrasonography here in labor room to rule out the placenta accreta spectrum? Yes.
Yes. If the ultrasound is available and the obstetrician is acquainted with the features of the adherent placentas, yes, definitely. That will be a good boon for the decision making regarding.
I think nowadays in this era we should, after 45 minutes of the placenta is not separating and she's not bleeding also. So we have lots of time in our hand, definitely, correct?
Yes.
So we have to rule out the placenta accreta spectrum or the morbidly adherent placenta before touching or trying to attempt separation, correct? Otherwise, the patient is stable, and when you try to pull it out, either she may land up into profuse bleeding or
inversion.
or maybe uterine inversion, correct?
Yeah.
So go for ultrasonography, correct. Now, what else you want to do for this patient? Once you do her ultrasonography, you find that there is no adherent placenta. Then,
if there is no adherent placenta after starting the ecbolics, also if the placenta has not removed, I want to shift the patient to the OT by keeping 1 pint of, at least minimum 1 pint of PCB ready.
Yeah.
And
this patient has come from outside, suppose, and you find that she has traveled for some time. Maybe they're afraid of giving her lots of fluid also, and she's not passed urine. Her bladder is full.
Yes, bladder should be catheterized first, because that will be the first hindrance for the. It might be a simply retained placenta, and just if we catheterize the bladder, most of the times the placenta will get delivered on its own.
And
if
full
it is
bladder
simply
also
retained
leads to
placenta.
uterine autonomy, right?
Yeah.
So, okay.
So then we'll start ecbolics, and if still the placenta is retained, I just want to shift the patient to the OT. With a conversation with the anesthetist, I want a good relaxation. So accordingly, preferably in the GA, because it will give the good relaxation, and I will make a fist of the hand and pass the hand along with the cord, and just want to try grab the uterus from the fundus. At the same time, I will ask the anesthetist to give the relaxant, so that I will separate the pass my hand easily in the uterus and try to separate the placenta in the lining of the membranes. Swipe the hand gently in between the uterine wall and placenta, and try to remove the placenta. In 99% of the times, we will be successful by this method. If it is the simply adherent placenta, we can remove the placenta, and after removal of the placenta, I want to keep my hand inside and ask the anesthetist to start the oxytocin to avoid inversion in such cases, and increase the uterine contraction retraction, so that the uterus will not invert.
What else you want to do at this point of time? You have removed the, you are going along the placenta, reaching the edge, you are insinuating your fingers, trying to separate the placenta, you are turning it like, how it is described, like a page of a book. Then you are trying to remove the placenta outside. Now, do you want to examine the placenta?
Yes, at the same time, I would like to examine the placenta once I confirm that uterus is now retracting. I will take out my hand out and I want to check the placenta, because sometimes we are dealing with a
maybe I would just interrupt you here, Gauri. Maybe your assistant will show you that yes, it is complete, because your one hand has to be there inside to see that nothing else is remaining inside.
Yes, ma'am. And same time, I will let my assistant to check whether the placenta is complete or not. Sometimes retained cotyledon or succinturate lobe of the placenta we might miss. To avoid that, again, we'll do check the placenta and confirm that placenta is complete.
Correct.
And continue oxytocin, as you have already told that she might have the chances of inversions afterwards. So to avoid that, we'll continue with the ecbolics.
Yes. So here not only the inversion, but even the PPH, because it has taken so much time and it was atonic also. That is why the placenta has retained inside. So
And one more
after removing the placental bed may bleed profusely.
bleed. Yeah. One more thing I want to add. We are doing the manual removal. So at the same time, I want to start with a higher antibiotics.
Yes.
Because we are removing placenta manually. It may sometimes turn up later that there might be a local endometritis. So to avoid that, I will like to start the higher antibiotics also in this
So
case.
oxytocin and higher antibiotics.
Yeah.
So very well discussed, Gauri. And now we go to Dr. Arushi for this next case. We have this, second gravida paragon, 36 weeks pregnancy with history of previous normal delivery. Now she has come as strong labor pains. Vitals are normal, fetal heart is good. Now she is, she has just come to you. When you examine, cervix is fully dilated, fully effaced, and you find that it is a breech presentation. Station is already +1. Pelvis is adequate. So thinking that, previous one normal delivery, but all of a sudden you find that it's a cervix fully dilated, fully effaced cervix with breech presentation. How do you tackle this patient? Dr. Arushi?
Hello.
Yes, yes.
Good evening, everyone. First of all, thank you very much for this great opportunity, ma'am. Coming to the case, the first question to be interpreted is like whether we should go for the normal delivery or attempt for the normal delivery or the decision of cesarean section.
Should we call this as normal delivery? I would ask you for breech presentation.
Sorry, ma'am. It's a trial of
Vaginal
breech
delivery. Vaginal.
Yes.
Okay.
Trial of breech. Vaginal delivery or decision of cesarean section. So for this, the Jatachny Andrews breech score may help us, which considers the parity
Arushi,
of
my
the patient.
dear, I'm so sorry. I'm again interrupting you. You have this fully dilated, fully effaced cervix and breech at +1 and she's pushing. Do you want to assess
Yes,
the score or do you want to, sometimes what do you feel about this patient? Whether you need to take
About
her
this
for
patient-
cesarean section or need to deliver her vaginally by assisted delivery techniques, what do you feel?
Actually, all the things are favorable, ma'am. Like she has a previous normal delivery, and even she is fully dilated, and the vertex station is also favorable. So definitely, we will go for assisted breech delivery.
Sometimes even you can think, you are just wondering, my God, breech has come, you keep the baby tray ready, you keep the IV fluids ready. Before that, she just throws out the baby. That is spontaneous vaginal breech delivery, right? You may
Yes,
not have
ma'am.
experienced this, but
That
this
may
can
happen.
happen. Yes. So
Yes.
first and foremost, you keep yourself ready for everything. Okay. You call for help, get your anesthetist, get your one more colleague, get your neonatologist, and put in IV line and now say whether she can deliver vaginally. Yes, I'm ready. By the time you keep the operation theater ready. Okay. So
Yes, ma'am.
suppose now you are, you feel that this baby is going to deliver vaginally. So how do you conduct assisted breech delivery?
For assisted breech delivery, everything we have to be prepared. Like we have to prepare the anesthetist whenever the anesthesia
That we
is
have
required.
already said. How you will allow the baby to come out?
Okay. The patient is shifted to the labor room when the buttocks as well as anus of the fetus is visible. The patient is already in the labor table, and the three principles we have to follow for the assisted breech delivery are never to pull. Second principle is always push from above and never to rush. And the third principle is always keep the fetal back anteriorly. These three principles we have to follow, and it is expected that maternal expulsive forces, as well as the pressure which is given by the assistant, maintain the flexion of the head, which assists in delivery of the fetus.
Yes. So she's pushing up. The baby is coming out Up to what? Yeah, at least you should
Yes,
not,
ma'am.
give traction. The baby should be, hanging up to the umbilicus. Let it deliver spontaneously up
Yes,
to
ma'am.
umbilicus. Okay. Then what
Next,
do you cover it, wrap it with a towel.
When the buttocks are delivered as well as um, till the trunk, the baby's body slips up, then we cover it with the towel, and
Yes.
after that the extended, in case of frank breech, the extended legs are released by putting the pressure in the popliteal fossa. By abduction and flexion, the legs are released, and the umbilical cord is pulled, and it is kept in the sacral bay to minimize the
That
compression
is
of
called
the
as
cord.
Peanuts maneuver.
Yes, ma'am.
Peanuts maneuver. You
Peanuts
give a
maneuver.
tap, so you get the foot, you pull it out. You give the
Yes,
tap in
ma'am.
the popliteal fossa, right?
Yes, ma'am.
Okay. Okay.
And
Now
after
both
that,
the limbs have come out. Both the lower limbs have come out.
Then next step comes the delivery of the arms. Here we have to assess whether the arms are in the flexed position or in the extended position. In the flexed position, the arms are delivered one by one by just hooking the finger in the elbow and just pulling the arms.
Yes, just deliver it. Go up to the shoulder, just slightly like this. Splint it over
Yes,
the
ma'am.
humerus. Okay, then let the
If
baby
the
hang by its own
scapula,
weight.
yes, ma'am. Like if the scapulas are winged, there is a winging of the scapula where there is extension of the hands, then we have to go for left Z maneuver, where the baby's trunk is already wrapped in the towel. Then it is turned 180 degree, so that the posterior arm, which is present in the sacrum, it comes
like this
below the pubic arch. We have to take care that back is always
half
facing
circle.
anterior.
That is 180 degree. Complete
Half circle.
half
Yes.
circle. Yes. Okay.
180 degree we have to rotate
Okay.
again
Now
in
we
the
rush
reverse
our
direction,
little.
180.
We rush our little. You
Yes.
have delivered up to this very nicely. Now
Yes,
the
ma'am.
head got stuck. How would you deliver the head? Delivery of the
Next is the
after coming.
next step is the delivery of after coming head. There are several methods. In that, the first method is Burn Marshall method. In this, the baby is allowed to hang by its own weight, and the assistant will give the suprapubic pressure in the downward and backward manner, so that the head flexion is maintained. And after that, the baby is held. The baby is held by the ankle with a finger in between, and when the nape of the neck is visible, then by maintaining the traction in the forward and the upward manner, the baby is pulled upside, and
towards
with the left
mother's
hand we have to
towards mother's
yes
abdomen.
towards the mother abdomen.
So that is Burns
And with the left hand we have to deliver the face and the brow, and then the trunk is again delivered. It is depressed down, so that we deliver the rest of the head.
Okay.
This is the Burn Marshall method.
No, suppose that doesn't help. You are trying to go like this, but if the head is not coming down, next what? You have to work immediately. Fast. Next what?
Next is the we can go for forceps delivery, ma'am.
Not Morris
Forceps delivery in this.
very easy technique that is.
We can try that also.
Yeah.
3 fingers. 3 fingers we have to use. Index finger and the middle finger we have to keep on the malar section, malar eminences, and the baby is put on the supine arm, supine position of the left arm, and with the right hand, these middle finger and the ring finger should be present on the right shoulder, and the middle finger on the occipital eminence, occipital eminence, and the index finger on the left shoulder of the baby.
Okay.
Then we have to give the traction and to increase the flexion of the head, so that the delivery of the face and the brow happens. After that, the mucus occurs. All the mucus which is present in the mouth is removed.
Okay.
Then
Very good.
depress the tongue to deliver the rest of the head.
Okay. So suppose you want to avoid a case, what RCOG suggests that if you find that a breech presentation at 36 to 37 weeks, 36 weeks, you try and offer them a ECV, which we are not doing nowadays for various reasons, but they are still doing it, external cephalic version. Suppose she denies or you do and it fails, then of course you have to give them a choice whether you want to go for elective Caesar or elective vaginal delivery. That is how you have to explain what are the possibilities of the even inevitable stillbirth at 39 weeks and all those introduction complications during vaginal breech delivery. That you have to explain. Of course, if it is a preterm baby with breech or if it's a second of the twins, then you may not go for elective cesarean section. That is what it has been recommended. Definitely you have the Zartuchini-Andrews score. All of you know this, or it is available. So you need to know this to decide whether you can go for vaginal breech delivery for this patient, whether it is favorable or not. So here it is clearly mentioned, if the score is less than 4, then you should go for cesarean delivery directly. If it is more than 4, you can see the more scores there, favorable scores. If it is multi-para, if the baby size is average, if it is, the dilatation is full, good, station is, little down. So this is a favorable score. Okay. So lower score, you have to go for cesarean section. That is what I think. Should we continue with the last case or should we stop here? I think all of us have discussed one case, right? Is there anybody who has not discussed? May I know? Yes, Dr. Aparna, Dr. Mohini,
Yes.
should we continue with this case? we have this very interesting case of shoulder dystocia. Dr. Manisha?
Yes, ma'am.
Yes. So I'm sure you'll be tackling this in short very nicely. We have
Yes.
34 years, second gravida with gestational diabetes. She comes to you in labor, and when you examine, you find that the head is almost 3/5 palpable. Fetal art is good, and cervix is fully cervix is only 2 centimeters dilated. Labor progresses normally, and now she becomes fully dilated and she starts bearing down. But even after 20 minutes of full dilatation, nowadays you have heard what is the duration of the second stage. It's not only the full dilatation, but the active pushing. So this lady is pushing actively. The head is delivered, but the shoulders are stuck. Very clear-cut diagnosis of shoulder dystocia. How will you tackle? Dr. Manisha.
So first of all, I want to say that shoulder dystocia. Yes, ma'am. So first of all, I want to say that shoulder dystocia, it is again one of the nightmare for the obstetricians. First of all, we can prevent these complications. Assist this patient prior to the patient goes in labor. So we should consider the mnemonics like DOPE. So patient is diabetic, obese, macrosomic babies, post-dated pregnancies, all elderly gravid and baby weight is more than 4 kg. Straight away we should go for cesarean section. Now what case you have informed to us, this is a clear-cut case of a shoulder dystocia. As we know that shoulder dystocia have 2 types. One is a complete shoulder dystocia. Second is anterior shoulder dystocia or posterior shoulder dystocia. So whenever there is a turtle sign is positive, that is a baby's head is again going back to its original position, then that is a clear cut. First thing what I will do, that I have diagnosed that this is a case of shoulder dystocia. I will call for help. My colleagues, I will call my health assistants also. I tell to stand by because I may need their help. Then I will do first maneuver that. The simplest maneuver, and 60 to 70% of the cases will be delivered with this Mac-Roberts maneuver. Mac-Roberts maneuver is a simple way to explain this is the excessive, means exaggerated lithotomy position, what we are routinely giving in our day-to-day practice in OPD. So we have to just flex and then abduct the legs of the patients towards the maternal thighs so that knees are trying to touch to the chest of the mother. And by that way, we can try to deliver the baby here. AP diameter is slightly increases, but most important thing what is going to happen here is a straightening of the sacrum, which will help to rotation of the baby, and we can deliver the impacted anterior shoulder, which is behind the pubic symphysis. If that is not working, then we have to go for a Rubin's maneuver, where we have to do a suprapubic pressure and try to dislodge the that is anterior shoulder, which is impacted behind the pubic symphysis. If it is not also working, then we have to go for extraction of the anterior shoulder or posterior shoulder.
Dr. Manisha, Dr. Manish, I'm
Yes,
sorry
yes.
to interrupt you. For the house's information, I just want to ask you to clarify, where should the assistant give the suprapubic pressure? Because that is very important.
It should be just above the pubic symphysis.
Yes.
And that should be towards the
occiput, on the side
occiput of the fetus head. Yes, yes, yes.
Otherwise,
And
in
second
fact,
thing,
it may worsen the situation.
yes, yes, definitely. And one more important thing I want to say, once I diagnose with a shoulder dystocia, one my senior colleague should go and talk this condition with the relatives. That consent also has to be taken, because this is a dial emergency. We can't prevent it. We have to handle the things. But there are certain abnormal, that is outcomes of the babies can become so worsening, like cerebral, that is brachial plexus injuries and humerus fractures. All these things can be happen. So medical legally, to avoid all these complications, we have to explain these things meanwhile. And we have to discuss this case with the relatives by one more senior colleagues who is going to take care of that thing. Then secondly, in spite of Rubin's manure, if the baby is not going to deliver, then I will go for next Rubin's 2 manure, that is extraction of anterior shoulder or directly extraction of the posterior shoulder. If it is not working, then we have to go for a corkscrew Woods corkscrew manure, where we have to rotate the shoulder in 180 degrees Celsius and try to deliver the impact, try to bring the anterior shoulder in a posterior direction, and then we deliver the posterior shoulder. These are nowadays things. If the baby is not going to deliver, then we have to go for Zuvenil's manure, where we have to push the head back to the position into the vagina, and we rush section.
Yes. Only what not to do, that also you have to remember.
Yes, we should not push from the above. We should not pull from the below. These things we have to follow.
Suprapubic pressure. It should not be a
Yes.
pressure, and do not give excessive traction in an attempt to hastily deliver, because whatever amount of traction you apply, it's not going to come unless it is, negotiated. The shoulder just sits. So that is what I think. We have almost come to an end. We will skip this case, and I would just like to, congratulate all of you for, contributing very nicely to this panel discussion. I'm very happy. All the panelists are very learned. I would just give one, very important take-home messages, that whatever the situation, first and foremost, you have to be very alert. You have to, have high index of suspicion. So you have to know the predisposing factor and try to avoid the exacerbating factors. You have to diagnose this at the earliest, but do not panic. Call for help. Calling your colleagues, whether senior and experienced or junior and expert, doesn't make any difference. You don't have to hesitate for that. So you and your patient's safety is very important. Vigilant monitoring is very important. Timely and appropriate intervention, and of course, documentation of whatever you do and counsel the patient and relatives is very important. So intelligent anticipation, skilled supervision, prompt detection, and effective institution therapy can prevent the disastrous complications of the consequences. Of course, not to forget the communication and documentation. So with this, I thank all the societies, the Kolhapur, Karad, and Ichalkaranji societies. I thank respected dignitaries, Dr. Jaideep Tang, Dr. Pardesi sir, Sujata Davi madam, of course, the learned speakers, Dr. Bhaskar Pal and Dr. Madhuri Patel, and guest of honor, Dr. Somshekar Patil and Dr. Bharti Abhankar. And I thank all the chairpersons and panelists for being so interactive and, contributing so much to this discussion. With this, I thank all of you, and I humbly to all of you to support me from all of you, your societies, your friends, colleagues, for my candidature as Foxy Vice President. If you feel I deserve, please do vote for me for the upcoming elections. Thank you so much once again. And over to you, Monica, once again. Thank you so much.
Thank you.
Thank you, Sneha madam.
I
It was
thank
wonderful.
especially Dr. Somshekar Patil, who is still here till the end of our discussion. Dr. Somshekar, any comments from your side?
Yeah, it was a very wonderful session and very much useful. My PGs are with me listening, so they had a very good lecture, and it was very much useful for them.
Thank you so much. Thank you. Yes, over to you, Madan. Anybody else wants to comment anything?
Yes.
Dr. Preeti, we can have their comments.
You are muted.
Muted.
You are muted, madam. Okay.
Okay.
It's okay.
Thank you so much. Thank you.
Yeah. Thank you all.
Thanks for joining.
Thank you, ma'am.
Thank you, ma'am.
Thank you, madam.
Thank you so much. Thank you. Thank you, Dr. Aparna. Dr.
Thank you,
Mohin.
ma'am. Thank you so much.
Thank you so much.
Thank you, ma'am.
Yes, Dr. Shantinath Kole.
Yeah, thank you, Sneha ma'am.
Sir, thank
Like,
you
it was
so
wonderful
much.
session.
Thank you for joining. And
Thank you, ma'am.
yes, please do support from your society and friends, colleagues, whosoever are the voters for me. It's not, I'm a private practitioner, like a majority of you, since last 32 years now, but I'm maintaining my academics as well. And I'm working for the organizations also. So if you feel I deserve, please do vote for me and support for me. Thank you
Sure,
so much.
madam.
Yeah,
Yes,
definitely.
Best of luck, madam, once again.
Thank you. Thank you so much.
Yeah.
Thank you, Madan, and thank you, Monica. Thank you so much. Thank you, Sahiti, for the wonderful conduction. Thank you.
Thank you, ma'am.